How have you been feeling since we last met?
I'm still feeling tired all the time.
Right.
It's interfering with my studying.
Right.
I'm finding it difficult to concentrate because I'm just feeling tired all the time.
Tiredness is a very common presenting syndrome in general practice. Some of these patients are disabled by chronic fatigue syndrome. It can be very frustrating working with patients with chronic fatigue syndrome, particularly as you can get into arguments based on their preset ideas about what causes the problem and what sort of treatment they want. This video is going to help you manage these patients, and it's going to give you lots of practical tips so that your patients with chronic fatigue will be more satisfied with their medical care. Dr Trudy Chalder is a specialist in chronic fatigue syndrome at the Institute of Psychiatry. Right, so we've got these people that come in to see us in general practice with tiredness, and then, you know, we've excluded anemia and underactive thyroid and things like that. How do we then know whether it's normal tiredness or at the other end of the spectrum they've got chronic fatigue syndrome?
Well, the main differentiating characteristic between normal tiredness that we all feel from time to time and chronic fatigue syndrome is the disability that people are experiencing. And sometimes we see people in our clinic who are completely disabled, i.e. they're bedbound most of the time. And at the other end of the spectrum, there's people, the CFS spectrum, there are people who are managing to go to work but are doing nothing in the evenings and then collapse all weekend as a result of the tiredness.
Ah, right.
So it's people who get into that all or nothing approach to activity and everyday life that you need to worry about.
Right. So how common is chronic fatigue syndrome as opposed to normal tiredness?
Well, chronic fatigue syndrome is not that common. About 0.2 to 0.5% of the population fulfil the criteria for chronic fatigue syndrome.
Right.
Although I have to say it feels a lot more when you think about how many people we're seeing in our clinic.
Right.
And about 10% of the population feel tired all the time.
Right. So the average GP with a list of about 2,000 patients might expect 3 or 4 patients,
Yes.
possibly with chronic fatigue syndrome,
Yes.
but literally dozens with tiredness up the other end. So if we can focus now on the chronic fatigue syndrome a bit more, what are the sort of the key criteria? How would you make the diagnosis?
Well, obviously the main thing is whether the person's experiencing physical and mental fatigue. They usually will say that the symptoms are made worse by exercise or activity, and so as a consequence of that they will have reduced what they're doing in response to the symptoms and will be substantially disabled.
Right.
And in order to fulfil the criteria, it's an arbitrary cut-off, but they have to have had a 50% reduction in activity levels.
Ah, okay, right. Over what period of time?
Over a 6-month period.
Right. At this point, we've found it useful to give you an opportunity for discussion. When the stop caption appears, we would like you to stop the video and have a discussion amongst yourselves on what a GP should ask during a first consultation with a tired patient. What are the important tasks at this stage? To show you how a GP might assess a patient with possible chronic fatigue syndrome, we have reenacted an actual consultation. The GP is Dr. Jenny Law. The patient, for reasons of confidentiality, is played by an actor.
Vince, hi, how are you? How have things been since I last saw you?
Bit worse, actually.
Oh dear.
Yeah, that's why I'm here again. It's actually quite a lot worse than when I last saw you.
In what way? What's been happening?
Much more tired, much more exhausted than I was, and it's beginning to quite seriously affect work. I'm having quite a lot of time off sick at the moment.
How much time have you had off in the last month?
Probably at least 1 day a week, quite often 2.
And what do you feel, what's actually stopping you from going to work? What's happening?
I'm just waking up in the morning feeling like I haven't been to sleep. Utterly shattered, very hard to get going, and even on the days when I do get going, it's difficult. But a couple of days I just can't make it at all. Can barely get out of bed. So.
Right. What about in the evenings and at weekends? What's happening then?
I'm basically just recovering because I work as a teacher, and there's quite a lot of homework that we're supposed to do, and barely up to that And after doing whatever of that I can do, I'm just crashing out and, going to bed about 9, spending a lot of the weekend sleeping, basically.
And in terms of having the time off work, what do you think is actually stopping you from going to work? What's happening with you? Is it that you just feel you can't, or...?
It's not so much a matter of feelings, it's just that if in a day when I'm feeling really bad, if I push myself too hard, then it just knocks me out. Like if I try to go to work in a day when I'm feeling that awful, I wouldn't be able to go to work for the next 4 days if I push myself too hard. Because it just completely knocks me out.
And are you able to do any social activities, and get out and see people? Or no?
I'm trying, because I'm aware of getting quite isolated at the moment. I don't want that to happen, so I have been, trying to see people, but that's becoming more of an effort than it was. I can do it and enjoy it at the time, but if I stay out too late, then it knocks me out for a couple of days. So again, I've had to stop doing that, or I've had to cut it down quite a lot.
Right. And Vince, I'm sorry, I can't remember. Have you got a partner at home? Have you got support, or is
not really? I mean,
there?
Again, it's like most things are becoming difficult. Managing the house, cooking, really basic stuff's actually at the moment very exhausting.
Right. So, have you any ideas yourself what might be causing this? Any thoughts?
Well, I've talked to a couple of colleagues about it, and to me it sounds very like ME, which I don't know an awful lot about. I've done some reading,
Right.
but to me, from what I've read and from what I've heard, it sounds like I've got ME.
Well, from what you've told me, and the symptoms with the muscle pains and the fatigue and everything, I think you may well be right. It's what I would call chronic fatigue syndrome,
Right.
Which is essentially just another name for the same thing. It means the same thing to the medical profession. What sort of things have you read about it?
Nothing particularly consistent. I mean, what I can make out is it seems to be caused by a virus, and it's caused by a virus that has in some way damaged my nervous system or my muscles, which is certainly what it feels like. It feels like my muscles are damaged. I used to do a lot of sport, and I can't do that anymore. My muscles feel very different from what they did.
Right, well, what I can tell you is that certainly in the past people have speculated about the link between viral infections and ME, or chronic fatigue syndrome, and there's no definite link between one and the other. Most common viruses are known not to be the cause of it, and it's thought that people who become fatigued and have this, there are a whole number of different reasons coming together, and therefore, if you did have a virus some time ago, which you link with this, your body would have cleared the virus by now. So there's no actual evidence in chronic fatigue syndrome of nerve damage or anything like that. So in that respect, there's no drug treatment as such for an infection that we would give you for it.
So there isn't actually any, because that's how it feels. It does feel like there's some kind of physiological damage.
Well, I mean, your symptoms, the physical symptoms are real, obviously, but there is no underlying nerve damage in chronic fatigue syndrome.
Right. So what can we do about it?
Right. Well, there is treatment that can help, and I can give you some advice about that, so we can talk about that.
Trudy, what was the GP doing there with Vince in that illustration that we've just seen?
She was doing 2 or 3 things. The first thing was that she was finding out how the fatigue affects his everyday life, and essentially how disabled he is.
Yes.
She also wanted to find out what he feels has caused it, because that may be important in terms of how well he'll engage with treatment, which I'm sure talk about.
Thinking about what she was talking about his beliefs about it. Is it important to sort of put somebody right if they believe that it's due to a virus or another reason? Does that help?
No, I don't think it does. I mean, I think it's important to incorporate that belief in a more sophisticated model of understanding the illness that you would share with the patient, if that makes sense.
Right, yes.
So for example, it might be the virus in conjunction with a number of other factors which contributed to the development of the fatigue.
Yes, I see. Now, with viruses, I mean, clearly there are some viruses that really do affect you badly, aren't they? Like the Epstein-Barr virus, for example. What do you normally discuss about viruses with patients at this sort of part of the assessment?
Well, some patients worry that they've got some virus lurking in their body that's still there, you know, months after the initial viral infection has gone away. And so it can be important to tell the patient that serious viruses such as glandular fever, hepatitis or meningitis, that they can cause fatigue 6 months after the onset, but that again it's likely to be a number of factors working together that causes the severity and the chronicity of the fatigue.
Right, right. And also in your assessment, what other things would you be looking for in terms of perhaps comorbid problems?
Well, the important thing from the GP's perspective is looking for depression and anxiety.
Yes.
And we know that up to 75% of people, both in primary care and in hospital populations, those people with chronic fatigue syndrome also fulfil a criteria for depression or anxiety.
So in that case, should the GPs be treating people with antidepressants, whatever, or should we be targeting particular patients for treatment, concurrent treatment with antidepressants?
If the diagnosis is clearly or primarily depression, where the person is experiencing loss of enjoyment, then I think it would be worth trying a course of antidepressants. But if the diagnosis is primarily chronic fatigue syndrome, then there is no evidence that antidepressants work. And I think that line of treatment would be unhelpful because it may actually alienate the patient, particularly if they don't feel that they're depressed.
Right. Now, on that idea about alienation, this is something that we often find in primary care. You know, we're trying to tell this person that it's a psychological problem. They're trying to tell us it's a physical problem.
Yes, yes.
How do we manage that situation?
Yeah.
Here is another chance for discussion. When the stop caption appears, we would like you to stop the video and discuss how the GP can avoid arguments with the patient.
I think first of all avoiding the term psychological, because it's unhelpful and it seems to me to mean lots of different things to different people. And usually patients think that you think it's all in their mind if you use the term psychological. Other people think that there's something lurking in the cupboard as yet undiscovered that is creating this problem. And of course that's, I think, in their mind a bit silly.
Right.
So I think it's best to avoid the term psychological altogether.
Right.
And just think about the problem in terms of how physiological, cognitive and behavioural factors are working together. And if you think about how what you do influences your symptoms, then it leads on to effective practical management strategies.
Could you perhaps expand on the physiological, cognitive and behavioural sides of how you would assess and how you would begin to start explaining the diagnosis to the patient?
Well, I think the diagnosis is quite clear, and we know that patients like to be given a specific diagnosis. So I think just saying that you do seem to fulfil the criteria of chronic fatigue syndrome is adequate. And I think the way the GP described the similarities between chronic fatigue syndrome and ME was fine.
Right.
And I think seemed to satisfy the patient well enough.
Yeah.
In terms of explaining how the way in which you behave influences your symptoms, I think you would start off by just asking them maybe to go away and keep a diary of their activities with a view to changing the way in which they manage their activities on a day-to-day basis.
Right.
So that will then influence how they're feeling. Although, of course, these changes, the patient will feel often takes quite a long time, weeks and even months.
Thanks for coming back. Now, what I wanted to do today was to go over with you how we're going to try and look at ways of improving the situation and helping you with your symptoms, which essentially is a practical approach, and the reasoning behind this is to try and break down the worry you have about undertaking an activity, then feeling absolutely awful, you know, shattered and tired, and then worrying about doing it again and feeling you need to rest. The idea is that if we can break that down by you working out some structured activity that you can undertake, that you will actually start little by little to feel better and feel less fatigued, because what's actually happened is that you've got yourself caught up in a vicious circle. So, you know, the more you do, the worse you feel, the less you feel like doing, so you rest, and then obviously if you do rest and you don't use your muscles, you know, they don't like it if you start using them again and undertaking activity. So that's, if you like, the sort of basic thinking behind trying to plan an approach for you and help you improve.
Right.
Does that make sense?
Kinda does. It's slightly worries me when you say worry, though, because it almost makes it feel like it feels like more than just worry about things getting worse. You know, when I do undertake something, it genuinely makes me feel that. I don't think it's just worry.
No, I'm not suggesting that it is just worry. I understand that, you know, there is a genuine physical tiredness and fatigue going on, but if you like, what I'm saying is that what you will need to do is undertake some of the activities that you know are likely to make you feel bad, and accept that even if you do feel bad, as long as you do it in a structured way and at regular intervals, that it will help. Now, it may be something like just taking 3 5-minute walks. Right.
Because I was going to say I've tried that. You know, I used to do quite a lot of swimming and go to the gym and stuff, and a couple of weeks ago I thought, okay, I could do some exercise because I'm aware that I'm losing strength. So I tried to go swimming, and it knocked me out for 3 days. So
when you're at the pool, what did you actually do? I mean, how much did you try and do?
I did what I used to do. I went and, you know, I did about 20 lengths, which is never was a problem for me before.
Okay. Well, I think what probably happened then is that you probably pushed yourself a bit too far, and that you tried to do too much. And what I'm suggesting is that if you start off just doing a very little and gradually build it up, that it won't have that kind of effect. As I said before, you may still feel tired, but you shouldn't feel so awful. And this is a process that's going to take, you know, some weeks. It's not, you can't expect to get back to full activity very quickly. We're looking at probably months of doing this, of gradually building back up. But the critical thing is to do it consistently and spread out, not to kind of rush off and do, as you said, you know, you did the 20 lengths, because that would make you feel awful.
Kind of sound. I mean, practically, how would it work? What kind of things are you suggesting that I do?
Well, in order to come up with a sensible plan of action for you, what would be really, really helpful is if you could keep a diary of the activity that you're currently undertaking. So what I'm talking about is a day-by-day account where you write down hour by hour what you're actually doing. So, for example, you don't need to do anything special. If you just get a piece of paper and you rule it up, and you have, say, the hours of the day, you know, the time down one side, so 9, 10, 11, etc. And then the days of the week, you know, Monday, Tuesday, etc. And just, if you roughly rule the paper up, or, you know, if you've got a diary at home, you could use that. And then each hour just make a very, very brief note, you know, had a rest, read the paper, went for a walk, whatever.
Right, so you basically want to know what I'm doing.
Yeah, so throughout the day, keeping a diary of it, then that would give me some idea of what you're basically able to do at the moment. And then if you and I met again in about 2 weeks' time, we can go through that, and then we can build on that, and I can give you advice about what sort of activities you could start increasing gradually, so that it would be it's a very practical exercise.
Okay.
Trudy, what's the rationale for this activity scheduling that the GP's just shown us?
Well, it's really important that the patient keeps a detailed diary of their activities and their rest throughout the day, so that you can then reorder all of the activities so that they become more consistent. So it's important that you ask the patient to break up their activities into small chunks, evenly spread throughout the day, so that the patient is then breaking the association between the symptoms that they're experiencing and the activity.
Ah, right.
Because people tend to get into the habit of stopping activity when they feel tired. So then, of course, the symptoms are controlling them rather than them being in control of the symptoms.
Right, yes.
So then you can see what they're doing and use that as a baseline for asking them to practice specific goals that you agree in the session.
Right. Now, going back a step, could you just perhaps tell us a bit more about why a diary is being used in this particular situation? What's the model behind it?
Well, it's important to make a clear distinction between the factors which contributed to the problem in the first place. Most people will mention a virus, but it's usually that in conjunction with a number of other things. And then factors which keep the problem going once it's started. And the factors which keep the problem going are usually people reducing their activity, because they're fearful that if they carry on with their activity, then it will make the problem worse.
I see. Right.
So what you're doing is asking them to reorder their activities,
Yes.
so that so it's no longer symptom dependent.
Yes. Now, is there something else that we would wish the patient to keep a record of by using a diary?
Well, it would be very helpful for them to keep a specific detailed diary of their sleep routine.
Right.
Here's another discussion point. When the stop caption appears, stop the video and discuss what kind of advice GPs should give to patients about their sleep.
So, Trudy, why is it important for the GP to take a good sleep history?
Well, first of all, most CFS patients that I've seen have had a disturbed sleep pattern, because they get into sleeping during the day when they're tired, and then of course if you sleep during the day, then it steals the sleep from the night time. And even though people feel extremely tired, they can't necessarily sleep more as a consequence of that tiredness. And so what happens is that they have a very disrupted sleep pattern, just sleeping for a short period of time and then waking up. So they don't have the average 8 hours solid sleep at night time, which appears, for whatever reason, to be very good for us.
Right, right. So it does seem then that if you sleep for the same number of hours at the same time each 24 hours, that has a beneficial effect on the syndrome itself.
Yes, it does. In fact, it has quite a dramatic effect on people's symptoms, and they quickly start to feel less tired.
Right, right.
You know, for example, I saw a young man in my clinic a couple of weeks ago, and he was sleeping most of the morning and then staying up most of the night, because he said that's when he got his creative energy. And I'm sure that's true to some extent, but we just reorganised his sleep so that, in fact, he was more creative in the afternoon rather than the evening or into the night.
Ah, so his creativity just shifted?
Shifted, yeah.
Oh, right.
Yeah.
Hello, Mick. Nice to see you again.
Hi.
How have you been feeling since we last met?
I'm still feeling tired all the time.
Right.
It's interfering with my studying.
Right.
I'm finding it difficult to concentrate because I'm just feeling tired all the time, just
Right.
as if I can't seem to get any energy.
Okay. I asked you to keep a diary
Yeah,
over the last
I
2
brought
weeks.
that along.
Lovely. Just looking at this, it is obvious that you have got a very, very erratic sleeping time. Here you went to bed at 9. Here you went to bed at 2 o'clock in the morning. You're also sleeping in a number of mornings a week, aren't you?
Yeah.
I notice that the late times are when you've been working in the pub.
Yeah, that's right.
Do you find that you're drinking maybe a lot more than you used to? Maybe using it to try and get off to sleep those nights?
Well, I mean, that thought had occurred to me.
Right.
That, maybe if I had a few drinks before I went back home,
Right.
that would help me to sleep a bit better.
Okay. I think what I'd like to do is to look at ways of altering this sleep pattern. Me and you together now look at ways that we can actually alter it to maybe get you to go to bed at the same time each night and to wake up at the same time each morning. Now, I want this to be realistic, What sort of time do you think you can actually go to bed at night?
Well, I mean, I normally get home, if I'm working in the pub, about 12 o'clock.
Right.
But one of the things that makes it difficult is that sometimes I have coursework to get in,
Right.
essays to write, and sometimes I stay up a bit longer
Fine.
and try and get some of that done. But imagine like 1 or 12 or 1 o'clock.
Okay.
Probably reasonable.
Now, as I said, there's an awful lot on this, and you are doing an awful lot in the average day. I mean, you're studying, you're working in the pub, you're having to do all this coursework. But I think if we can tackle the sleep so that you actually get your 8 hours sleep in every night, you will feel less tired, and you'll therefore have more mental energy left to do some of the studying.
Mm.
So I think we can make then 12 to 12:30 is a realistic time that you can go off to bed at night.
Yeah, I think that's
Okay.
as realistic as you can
Your
get.
lectures start at 9:30 in the morning, so what would be a realistic time for you to get up in the morning?
Well, I'd need to be up, I imagine, about 8 or 8:30.
Okay,
Yeah,
well
we
let's
get
say 8 o'clock then, and you've got an alarm clock at home, have you?
Yeah.
All right. Well, let's look then at you going to bed between 12 and 12:30 and waking up at 8 o'clock in the morning. Now, you're going to feel lousy. You're going to feel absolutely lousy at the beginning because you're not getting your lie in.
No, well, I feel lousy now, so I suppose it won't make that much difference. Will it?
Okay. Some people think it's very boring to sort of have set routines, and yes, I think a lot of people get their creative energy from working with the adrenaline rush, as probably you do sometimes, but I think in your case it's gone a little bit over the top, hasn't it? That's why, in a sense, you've come to see me feeling tired all the time.
Right.
Do you think that makes sense?
Yeah, I mean, I am doing quite a lot, trying to get through the MSc and do all
Right.
the studying on top of that, and working as well to get by.
The other thing is the alcohol. What sort of... I mean, you're obviously drinking erratically throughout the week. I just wonder, again, whether if we said let's limit the alcohol to 2 pints or 2 pints equivalent per night, whether that, again, would be something you would be able to do.
Well, that's okay, but if I go out socialising,
Right.
I go to a club or I go to a pub with friends, I'll probably feel a bit strange just having 2 pints when everybody else is carrying on drinking.
That's very
That's
true, and
really
it might be that you're going to the clubs at the weekend, is that right?
Yeah, that's right.
Well, let's say that maybe during the week, if you could limit your alcohol intake to 2 pints at night, and at the weekends, well, we'll look at the weekends at a later stage, but I think if it's not affecting your work at the weekends, then that's fine. But equally, a lot of alcohol acts as a stimulant, so the more alcohol you take, the more stimulated you'll be, and the more you'll find it difficult to get off to sleep at the normal times.
Okay.
Do you think you'll be able to do that for the time?
Well, I'll give it a go.
Lovely. So we'll meet again in 2 weeks.
Is there a difference then between people who are tired all the time and people with chronic fatigue syndrome in terms of their sleep patterns?
Yes, I mean, obviously this is a generalisation because some people with chronic fatigue syndrome sleep too much. They have hypersomnia. But equally it's true that they have insomnia or disrupted sleep pattern because of what we've just been discussing. They're sleeping during the day rather than at night time. But people with tired all the time syndrome, whatever you like to call it, often are not sleeping enough because they're trying to juggle too many things all at the same time. And so they probably need slightly more rest during the day and maybe a few more hours in bed than they're presently getting.
Right, so the advice would be quite different in their situation. Right, yes.
And in addition, sometimes people with chronic fatigue syndrome oscillate from one extreme to the other. From either getting too much sleep or not enough. And what they need is a consistent pattern of sleep.
Right. Here's a final opportunity for discussion. When the stop caption appears, discuss how a GP should manage these patients over the long term. What advice should you give about the diaries? So, Trudy, what's the rationale for this activity scheduling?
Well, it's really important that the patient keeps a detailed diary of their activities and their rest throughout the day, so that you can then reorder all of the activities so that they become more consistent. So it's important that you ask the patient to break up their activities into small chunks, evenly spread throughout the day, so that the patient is then breaking the association between the symptoms that they're experiencing and the activity. And the factors which keep the problem going are usually people reducing their activity, because they're fearful that if they carry on with their activity, then it will make the problem worse.
I'd like to review the diary that you've kept. I'd like to talk about treatment, and I'd like also again to talk about developing a consistent approach to activity, which is something we touched on last week. What do you remember about what we talked about that? What do you remember about that?
I remember you saying that I needed to gradually build up my activity bit by bit.
Yes. I think we talked about how important it was that activity was consistent throughout the week, rather than in bursts of immense activity followed by nothing. Is that right?
Yes, yes.
Okay. Can I have a little look at your diary? And just talk me through it.
Okay, well, Monday, Tuesday and Wednesday were fairly typical. I went to work, and when I came home I just did nothing, I just rested. And, Thursday I tried to do a bit more after work, so I was quite busy first part of the evening, and then just felt worse and worse. And I was so exhausted on Friday, I just had to take the day off, and spent it in bed recovering. Felt a bit better on Saturday, and that was a fairly normal weekend day where I was fairly sedentary, I suppose, watching a lot of telly, reading the paper. Sunday I thought, well, I've got to try and build up my activity and do more, so I went out on a big walk, which probably wasn't a very good idea, I think. It was a few hours. I did lots of rest along the way. I was walking very slowly, but I think, and I really regretted it by the evening.
So if I just recap, Monday, Tuesday, Wednesday were fairly normal days. Thursday you did some activity, and this was followed by you feeling exhausted Friday and Saturday, so that you had to take to your bed on Friday. And Sunday you did this enormous burst again of activity. I think what your diary shows is again how important it is that we develop a consistent approach.
Yeah.
Because what we talked about was that it's important that we break this association between activity and your symptoms.
Yes,
And
I can see what I'm doing. I just
because
it's hard to know how to change
You've got activity
it.
on Thursday followed by symptoms, activity on Sunday followed by how are you feeling now?
Dreadful.
Right.
I feel knackered.
Okay. So can you help me then? Over in a normal week, how can you consistently increase the amount, or consistently do some form of activity?
Well, I suppose I shouldn't go on these very long walks, and perhaps try and do a bit more each day.
Okay. We've talked before about the fact that you walk at the moment to the bus stop, is that right, to get to work?
Yeah.
How long extra would it be if you walked to the next bus stop?
Another 5 minutes. So it takes me about 5 minutes to get to the bus stop at the moment. The next one's about another 5 minutes.
So one way then is if you walked to the second bus stop in the morning and got off a bus stop early in the evening, you'd be doing 10 minutes of activity in the morning and 10 minutes of activity in the evening. Is that right?
Yeah, yeah.
And that would be an overall increase of 10 minutes in one day. Well, why not then, till we next meet, that for the week you did this extra 10 minutes a day, so that's 10 minutes in the morning, 10 minutes in the evening.
Yeah.
What could you do at the weekends? What, for a similar amount of activity, of walking?
Well, I suppose 2 10-minute walks each day at the weekend. That would be more or less the same. Well, it would be the same, wouldn't it?
Okay. So you can still potter around and do the things that you would normally do on a Saturday and Sunday, but what I would like is for you to have that 10 minutes in the morning, 10 minutes in the evening of activity. And it's probably better if you keep it consistent with 10 minutes in the morning and 10 minutes in the evening, rather than putting it together to do a 20-minute hike.
Oh, right. Okay.
Would that be all right? Do you think you'd be able to manage that?
I think I probably could. It would probably be a bit of an effort at weekends, but I think I probably could. But and of course, I mean, I can always do more, can't I? If I feel really energetic on a Sunday or something, then I can always do a longer one.
I don't think at the moment that you should do that. I think it is very important at the moment that we develop a consistency. And even if you're feeling full of energy, I don't want you to do more than the 10 minutes walk in the morning and the 10 minutes in the evening, and all the normal things that you do during the day, but I don't want you to do these bursts of activity.
Okay, well, I suppose if I'm not going on hikes, I probably would have a bit more energy in the week, would I? So probably make it a bit easier to do those 2 10-minuters.
I think it would, and I think what we're trying to do here, as I said to you, is to break this association between activity and your symptoms. Because equally, if you feel rotten, I still want you to do that activity that
Or
we've
even
set
if
out.
I feel really,
Even if you
really,
feel
really
absolutely
exhausted.
I still want you to do your 10-minute walk in the morning and a 10-minute walk in the evening after work.
Is that going to be safe?
It will be safe. All the evidence that we've put together and all the research literature shows that it is absolutely safe. You will not do yourself any harm. And as I said, it's important that we make your activity consistent across the week.
Okay.
So you'll be able to manage that before the next appointment.
Yeah, I think so. Yeah, that does sound just about manageable, I think. Yeah.
Good.
Why is the GP limiting the activity in that situation when somebody's got chronic fatigue syndrome?
Well, the most important reason is because patients with chronic fatigue syndrome get into this all or nothing approach to activity. When they're feeling good, they'll do masses of exercise or activity. When they're feeling bad, they won't do anything, or they certainly reduce the amount they're doing. Right. So it's important to develop the consistency, and that means not only maybe increasing the amount they're doing, but also stopping themselves from doing too much when they're feeling quite good.
So having done that, I guess the process really is, it has to be a slow, supportive, steady one, so that the GP's really got to help the person to very, very gradually build up their activities and but limit them initially. Is that correct?
That's right. I mean, I think we're thinking in terms of months rather than weeks. So the GP needs lots of patience,
yes,
as opposed to people,
yes.
to stick with it over a number of months and seeing the patient maybe once every 2 or 3 weeks to set new goals.
Yes.
And during that time they could discuss any difficulties that the patient's having.
Yes, and to keep the goals realistic, so
that's important.
Really sort of increasing them very, very slowly as appropriate.
Absolutely, and it's really important not to go too quickly.
Right.
It's much better to go slowly and surely,
yes.
And get there in the end than to do things too quickly and for it all to go wrong, which is what often happens.
Yes. Now, when things do go wrong, I mean, presumably it doesn't always work this way. What's the point where the GP should be thinking about referral?
I think if you've given it your best shot for about a year, at that point then I would think about why it's gone wrong.
Right.
And if you think a specialist referral would be helpful, then at that stage then...
Yes. Now, what sort of specialist? Because there are immunologists, psychiatrists, psychologists, there's all sorts of people that specialise in this area, aren't there? Who would you recommend? Resources willing, of course.
Yes, I mean, it's extremely difficult, but I think the most important thing is that whoever you refer to, whether it be the immunologist or the psychiatrist, that they're committed to a practical rehabilitative approach.
Right, yes. So it's this pacing approach the sort of key to it. So, so if a cognitive therapist is available, would you suggest that sort of...
A cognitive behavioural therapist, absolutely.
Yes.
So I think initially it's really important to focus on the behaviour rather than the way in which people are thinking.
Right.
It's because it's a bit threatening going in directly trying to change the way in which people think.
Yes, yes.
So initially it's just a very straightforward, pragmatic approach you need to stick with, over a long period of time, but bearing in mind that there are going to be times when things go wrong.
Yes. And
predict with the patient that they are going to have setbacks, but help them to plan how they're going to cope with the setbacks as and when they occur.
Yes, yes. Now, the other situation that myself and my partners in my practice often find is that
people go to the ME Association,
Right.
and they get lots of advice off the internet and newspapers and things, and they come in with a whole wealth of different agencies that they'd like to be referred to. But presumably it's more appropriate, really, to contain it.
Yes, absolutely.
And keep it simple in the way that you've just described, is it?
I think that's really important. I think if the patient's being investigated by a number of different specialists, then it's going to be difficult to engage them in this sort of rehabilitative approach. So I would try and negotiate with the patient, actually stopping that process, of having more investigations, which obviously is not always easy.
No, but that's very helpful. Now, then, to summarise, really what I think we've discussed is that people can be taught how to relearn or to change their behaviour and their sort of physiological processes in a way that can actually control chronic fatigue syndrome.
Yeah.
Is that correct?
That's absolutely right. And in fact, that's not really different to most other illnesses. You know, if somebody's got diabetes or heart disease, then essentially the health professionals are teaching people how to cope with their symptoms and disability.
Right.
And we know that the degree of pathology is not necessarily correlated with the degree of disability.
Right.
You know, so I think our
Yes.
job generally is about helping people cope.
Yes. Despite the fact that we've seen all these techniques that can be used, it does remain that a lot of GPs feel a bit pessimistic with these sort of patients. What do you think?
Well, I think it's true that GPs and doctors in general feel pessimistic about patients with chronic fatigue syndrome, but I think it's misguided pessimism. I think there's absolutely no reason for them to feel pessimistic at all, in that I've been seeing patients for about 13 years. Most of them have been extremely rewarding and who have made significant improvements, both in terms of their symptoms and disability.
Right. What percentage would you expect to get better?
About 70% in hospital populations, which is actually very good.
Right. Over what time would that be?
Well, it's obviously not going to be an overnight cure. It's going to take several months and sometimes up to a couple of years. But if you persist with it, don't give up and recognise that there are going to be ups and downs,
Right. Yes.
then patients will get better.
And if they're left untreated, well, the converse must be the case, surely.
Yeah, left untreated patients certainly don't get better and they deteriorate.
Right. Thank you.
Chronic fatigue syndrome patients are difficult. We hope that you will persevere with them. It helps to arrange firm follow-up and not to expect too much. Change often occurs over the long term. We've included with the package some guidance on using role plays to develop your skills in working with these patients, because we've found that it's only by rehearsing the skills that you need that you'll be able to use them when faced with the real situation. All that remains now is to wish you the very best of luck with it.